Hello, everyone. My name is Joel Bellesini. I will be presenting my master's thesis entitled Three-Dimensional Dynamic Optical Coherence Tomography for Breast Tumor Margin Assessment. And I would like to thank my supervisors, Dr. Ken Fu and Professor Brendan Kennedy, for all their support, as well as everyone here watching. Okay, so there's no question breast cancer is a significant problem in the Western world. Approximately 57 women are diagnosed daily, equating to 20,000 annually, placing breast cancer as the most diagnosed cancer amongst women in Australia, in which 1 in 7 women will therefore be diagnosed with breast cancer in their lifetime. Regarding different types of breast cancers, there are multiple types. There are those which are invasive, meaning they spread out across the breast tissue, or there are those which are in situ, meaning they reside within the region of the breast of which they And breast cancer can also further be subdivided into those which originate in the duct or lobule regions within the breast. And depending on breast cancer subtype and stage, surgical interventions vary, with breast-conserving surgery being the most common procedure, involving the removal of tumor and a small layer of surrounding healthy tissue, also sometimes named lumpectomy. And then in more drastic or later stage cancers, mastectomy may be opted for, which is essentially the removal of one or both breasts, either partially or completely. So breast-conserving surgery, as I mentioned, is the most common form of breast-conserving surgery. It accounts for over half of breast cancer surgeries in Australia, involving the removal of cancer and a rim of benign tissue, which we refer to as a margin. So just showing here in this diagram what we mean. Where there is a sufficient rim of benign tissue, we refer to this as an instance that a negative margin is obtained. However, if there is cancerous tissue still residing at the edge of the excised region in breast-conserving surgery, this is referred to as a positive margin and may indicate that there is still cancer residing within the patient. And this therefore requires re-excision. And in current states of breast-conserving surgery, it's a 20 to 30% rate in which re-excision is required due to positive margins being discovered in post-operative histology. And this naturally has its list of several negative implications, including and not limited to delayed or increased recovery times, delayed adjuvant treatment and poor cosmetic outcomes. And this is ultimately because surgeons are relying on visual and tactile cues in order to determine negative or positive margins, which is insufficient. And therefore, intraoperative margin assessment techniques are required in order to reduce this re-excision rate in breast-conserving surgery. Now, I mentioned post-operative histology, which is the current gold standard in tumor margin assessment. This takes 24 hours or over 24 hours to actually be performed, which goes without saying that this exceeds our requirement for intraoperative assessment, in which clinical restrictions would require performance for intraoperative assessment within an approximate time window of 15 to 30 minutes. So intraoperative assessment methods have been introduced, which I'll go through here. So imprint cytology is it is a simple and rapid technique for tissue diagnosis, in which an excised region is touched on a glass slide, and it imprints cells on the slide, which are then stained and may be studied in order to inspect what cellular or what tissue types reside on the surface of an excised region. There is also frozen section histology, which is a rapid method of tissue processing, in which the excised tissue region is embedded in a frozen medium and then may be sectioned and stained for immediate examination by a pathologist. However, in both cases, neither of these methods have been able to significantly reduce this re-excision rate due to having their own drawbacks. Namely, with imprint cytology, we are limited to just a single surface plane of inspection. Also, well-differentiated tumours tend to be quite dense and are resistant to imprinting, and therefore cannot be prospected with this technique. In the case of frozen section histology, tissue damage is quite often due to this freezing process, and therefore the acquired slides are rarely of high enough quality in order to administer a accurate diagnosis. So introducing optical coherence tomography, or abbreviated as OCT, as a potential solution. OCT is a non-invasive imaging technology which uses low coherence light interferometry to depict internal microstructural detail of tissues. It works in the most elementary or first description of OCT is our time domain system, in which a low coherence light source is split into two arms, which we call the reference arm, which hits a translating mirror, and then a sample arm, which will then be incident on the tissue or whatever sample you're imaging. And as light is reflected from the reference arm and backscattered from the sample, these two beams are then combined, and their interference signal is then measured at a detector. And due to the nature of the low coherence light source used, a detection signal will only be encountered at the regions within the sample at which the path length is equal to the reference arm path length. So therefore, one-dimensional images are able to be constructed with contrast indicative of the backscattering properties within tissue. And we refer to this one-dimensional image as an A-scan. Subsequent innovations on the time domain OCT system include spectral domain OCT, which works by emitting a broad spectrum of light and then measuring echo time delay over various frequencies. And in effect, what this means is that spectral interferometry is being performed in order to create identical A scans without the need of translating hardware components. And therefore, far higher A-scan rates or scanning rates can be acquired, which for our project, we're using a spectral domain OCT system, as high scanning rates will be critical for our protocol. Finally, there's also full-field OCT, which is another method of OCT in which entire two-dimensional images can be obtained all at once in the on-fast plane, which means not with or with a given depth, so not without depth information in a face-on plane, by illuminating the entire field of view. And then this backscattered light is pretty much detected by a camera or a 2D array detector. So as I mentioned, this lacks depth information, but it does allow acquiring of two-dimensional images all at once. And then just a little bit of the nomenclature that I'll be referring to with regards to OCT. Like I said, an A-scan is our one-dimensional image. By acquiring multiple A-scans over varying lateral spatial locations, we can form what we call a B-scan, which is a two-dimensional image. Over another dimension, we can then form a volume scan, and then this can then be sliced in to create our on-fast images, which is in our XY axis, so at a given depth. So putting OCT into context with other imaging modalities, it provides micrometer resolutions with a millimeter range penetration depth. And due to this, it has held application in fields of ophthalmology, dermatology, and is currently exploratory in oncological contexts due to its benefits in capturing detailed visualization of microstructures within tissue. So despite the practical advantages of OCT, the contrast between cancer and benign features in breast tissue is unfortunately often low. So therefore, functional extensions on OCT are required in order to enhance the obtained contrast. So among these is polarization sensitive OCT, in which changes in the polarization state of light is detected as it interacts with tissue, which provides increased functional information on breast tissue. Attenuation imaging is another method in which the attenuation coefficient is mapped in OCT, which corresponds to the extent at which different tissues are able to attenuate the incident light beam, which is also a promising approach in imaging breast tissue microarchitecture. And finally, quantitative microelastography is another technique which maps tissue elasticity, so structural information, with microscale spatial resolution, and is used to delineate microstructural features within breast tissues as well. However, each of these functional extensions, while they do provide enhanced contrast, they involve one of the following drawbacks, and that is either an induced requirement for additional hardware or a degradation of image resolution. So introducing dynamic OCT as another functional extension on OCT. Dynamic OCT is performed by taking multiple OCT acquisitions at a given location over a given time frame, in which information regarding the intracellular motion of the tissue or of the location which is being scanned is then extracted from temporal variance on OCT. And in doing so, there is no loss of image resolution or induced hardware requirement. What we are doing is we are looking for the motility characteristics within the different regions of our comprising tissues. And this information is typically prospected using Fourier transform. in which the power spectral density describes the power of our incident signal over various frequencies of motion. So we can look at different regions within the tissue and inspect their power spectral density and see how that varies, and then we can use that to create a dynamic image with enhanced contrast based on the dynamic signal. So promising developments have been presented using this image technique on breast tissue. However, this has been using dynamic full field OCT systems, which, as I mentioned, lacks depth information, which for our application in tumor margin assessment, this depth information is required, as it gives us our ability in order to detect and measure margin. Which three-dimensional dynamic OCT imaging can be performed and has been performed using spectral domain OCT. However, this has been on tumor spheroids and organoids and is yet to be performed on tissue scales. And this is essentially because three-dimensional dynamic OCT is difficult due to the increased dimensionality of data. So while it would allow complete volumetric tumor margin assessment, essentially we're taking images in 4 dimensions, 3 spatial and 1 time dimension. So our file size, our image sizes blow up really, really quickly. So regarding the significance and the aims of this project, firstly, we plan to acquire 3-dimensional dynamic OCT images of breast tissue, and in doing so, investigate a range of spatial and temporal sampling parameters to formulate a protocol for 3-dimensional imaging that still resides within a clinically relevant time frame, as we mentioned earlier at the start, with 15 to 30 minutes of acquisition time. Secondly, we also present co-registered histology to validate the dynamic contrast that we obtain against tissue morphology regarding a range of benign and malignant tissue types. There are also many methods of processing and visualization of the dynamic signal, and it is currently unsure which method may present the greatest suitability for displaying this contrast. So what we do is we perform and compare multiple different dynamic OCT visualization techniques. And then finally, by comparing 2 functional extensions on OCT, so dynamic OCT and QME, we perform both of these on a given sample and test to see if this may provide complementary contrast when co-registered with each other. Essentially contrast derived from different functional origins in breast tissue. And this, again, is something which is yet to be investigated on breast tissues. Okay, so regarding methods, a total of 10 female mastectomy patients and 4 female breast-conserving surgery patients at Fiona Stanley Hospital in Western Australia were all included, having provided informed consent before participation. Fresh excised tissue specimens were obtained, hydrated with saline, and then brought into contact with an imaging window such to minimize surface topology variation. And then all scans were taken using our d-OCT system as shown, within 1 hour of excision, such to preserve live tissue motility characteristics, as well as the quality of the subsequent histology slide, before undergoing standard histology processing to create a histology slide, which involves staining with hematoxylin and eosin. OCT wide field images were also taken, which were acquired by stitching multiple overlapping OCT subvolumes in either a 2x2 or a 3x3 grid. And this was used to co-register with our histology slide, but also were used to identify a region of interest for then dynamic OCT, which required over a 3x3 by 3.5 in-depth millimeter field of view. And this was acquired by taking multiple B scans per location. So as stated, we investigated a range of spatial and temporal sampling rates. Our rationale in doing so was acquiring highly sampled 2-dimensional dynamic OCT, which meant we took 2,000 B scans per location, and then observing the reduction in contrast in d-OCT images, which were derived by imaging what we call the Fourier-weighted mean frequency, which simply corresponds to the arithmetic mean frequency weighted by each frequency's magnitude. So I'll show those images here. So first, we've got a case from a mastectomy sample in which we have 2 regions which we have scanned corresponding to region A on the left and region B on the right, which has been indicated with a red and blue outline, where we present OCT images on the top and then dynamic OCT images on the bottom. And what we can see is when I introduce multiple images of decreasing B scans per location, we can detect a decrease in contrast within the regions indicated with the yellow dashed box corresponding to features in our histology. So what we can do is we can look at this and we can make the decision at what point contrast is cut off to a considerable extent. And then we derive the following set of optimal imaging parameters for three-dimensional dynamic OCT, in which at 200 B scans per location, we chose due to decision that sufficient contrast was obtained. And this places our total image acquisition time at 11.4 minutes, which resides within our clinical timeframes. And then in our different methods of visualization, the first of which I will go through now is the what we call RGB imaging, which is the most prevalent or most performed method in the preceding literature, involving integration of the obtained frequency spectrum over varying frequency bins, which are then displayed in an RGB image. So essentially, our frequency spectrum is integrated in a low corresponding to our red channel, medium frequency bin corresponding to our green channel, and then high frequency bin corresponding to our blue channel. And these are then imaged discretely in an RGB image. And these frequency ranges are somewhat arbitrarily chosen in order to accentuate variation in our frequency magnitudes between adjacent tissues. An adapted method, which we also performed, which we call HSV imaging, involves allocating metrics to HSV space, which stands for hue, saturation, and value in a two-dimensional image. And these metrics were derived from modeling our Fourier spectrum as a probability density function about a characteristic true frequency of motion for each location. So namely, our true frequency corresponding to the weighted mean frequency was visualized as the hue, which is the color in our two-dimensional image. The width about this mean value, which is the spectral variance about this mean, was then displayed as the saturation, or essentially the strength of this color, or the vibrance. And then the value, which is simply the intensity or the integral under the curve of our Fourier spectrum, was denoted as the brightness or the value channel in our HSV image. And finally, we also attempt a purely phase-dependent dynamic OCT image, in which the phase component from our spectral domain OCT data was extracted, and the mean squared time-sensitive phase difference of the incident signal was calculated and imaged in a two-dimensional image. This is essentially a measure of how much the phase signal is changing over our acquired signal duration. And this has been hypothesized to increase our sensitivity to finer scale motility variations by phase-sensitive tissue dynamics, and has been performed in these two papers here. It's also worth mentioning this is another case that is yet to be performed, processing method, which is yet to be performed on breast tissue, which we then perform in our subsequent results. So first result, present a mastectomy scan containing pleomorphic invasive lobular carcinoma, which is a type of invasive lobular carcinoma, which is characterized by high activity and a high proliferation rate. As well as in this case, we had regions of lobular carcinoma in situ around this region of PILC as well. So what we see as I introduce our OCT and subsequent dynamic OCT images, as these grayscale images on the left, OCT intensity on the left, and dynamic OCT on the right, is that we see strong enhanced contrast between benign and malignant regions, in which this region of PILC and LCIS are shown with enhanced contrast in our dynamic OCT images in both on-FAST and B-scan planes. So this is also a demonstration of volumetric assessment, in which, we are able to determine this border between benign and malignant tissue with far stronger capability than we were with conventional OCT alone. And then introducing the three different visualization techniques as well, we can say that the method which presents the strongest contrast is the HSV method, which also seems to depict finer microstructural detail, which can be observed, outlined by the white arrows within the PILC region, where the RGB image still shows strong contrast, but doesn't have as strong microstructural detail due to the discrete nature in which we are imaging over 3 frequency bins. And then finally, our phase variance image seems to have reduced contrast due to greater influence of noise. And there are some features of enhanced contrast, but lacks co-registrability in this case. Cool. So moving on to our next case. This was another mastectomy scan of a region containing invasive ductal carcinoma over the entire field of view. And what we can see when I introduce OCT, dynamic OCT, and also QME, this was also a case where we took a quantitative microelastography scan for comparison, is that we can see strong contrast introduced in our dynamic OCT corresponding to microtubule formation or dense microtubule formation, which are the small purple microtubules that are visible in histology, which we can detect in dynamic OCT as regions of lower frequency, which were previously undetected in OCT. What's interesting is that this phenomenon is indicative of cancer type and grade. So the fact that we can detect it in dynamic OCT shows that it is able to be used for detection of grade and cancer type. And we also are able to compare our dynamic OCT image with QME, in which in the QME image, due to the reduction in resolution, these microtubules aren't as easily detectable. However, what we suspect we can see, if I zoom out on the histology, is a larger scale variation in elasticity from high elasticity on the right to low elasticity on the left, which corresponds to a more global change in stromal composition across this tumor. Notably, the region towards the outside of the tumor, as it is growing, we refer to as the proliferation zone, which is characterized by a presence of younger stroma, which tend to be less dense. And we believe this is what we're detecting in the QME image. So this signifies that these two functional extensions of OCT are prospecting complementary contrast from different functional origins, which is also very interesting. And then introducing different our visualization techniques. Again, our HSV plot seems to present the strongest microstructural detail, but it's not particularly strong in this case due to what we think is clashing of contrast between the subsequent channels. And then our RGB and phase variance plots have similarly decreased contrast compared to our HSV. Okay, final case, we've got a lumpectomy scan in this instance, or breast-conserving surgery scan, in which this specimen contained invasive ductal carcinoma. Another thing worth noting is for lumpectomy scans, the way in which the histology is processed is it's actually in the B-scan plane rather than the on-fast plane. So essentially, we're looking at a top-down or the Y is essentially depth in this histology slide. So when I introduce our OCT and dynamic OCT images, what we can see is that we observe contrast corresponding to a region of benign tissue, which is fibrous stroma at the border of this region, to a deeper lying malignant tissue, which is, as I said, IDC. This contrast has been introduced in dynamic OCT, which was previously undetected in OCT and is consistent with the structural and functional differences between comprising tissues. And again, we can see our contrast is strongest in our HSV depiction. The most significant thing about this result is that this provides a direct demonstration of the clinical utility of this method for breast tumor margin assessment, where we are able to detect a margin of benign tissue against deeper lying malignant tissue in a B-scan plane. So yeah, this result kind of tends to the clinical significance of this method for margin assessment. Okay, final result, we also present a statistical analysis of dynamic OCT metrics regarding breast cancer types of interest, in which a mean contrast to noise ratio has been derived for each of our different processing methodologies. And this contrast to noise ratio has been taken from benign and malignant tissues. So it's essentially a measure of how much each of these processing methods are able to extract contrast between benign and malignant regions over a given size of a box. And what we can see is that our Fourier-based metrics, so namely the Fourier weighted mean frequency and Fourier spectral variance, are the strongest in bringing out this contrast between benign and malignant regions, opposed to the OCT or the standard deviation of the OCT or the phase variance in this case. So to summarize, in our results, we performed three-dimensional dynamic OCT imaging on freshly excised breast tissue samples. This was performed using a devised three-dimensional scanning protocol using a spectral domain OCT system. Our dynamic contrast that was obtained was linked to breast cancer morphology detected through histology, and this is obviously promising for prospective clinical implementation. A quantitative analysis has been performed on dynamic OCT image processing and visualization methods, in which our Fourier-based methods have been presented as the strongest at presenting this enhanced contrast between benign and malignant tissues in breast cancer. And finally, co-performance with another functional extension of OCT, QME, provides discrete and complementary functional information, which opens the door to multimodal OCT imaging techniques where complementary contrast for a given field of view could be obtained through multiple methods. So to conclude, this demonstration frames three-dimensional dynamic OCT as favorable for clinical translation as a more effective method of intraoperative breast tumor margin assessment. However, there is future work which must be applied to this field in order to get there. Namely, there is a performance on a wider scope of samples will be required for a diagnostic accuracy study of dynamic OCT. Ultimately, we were limited to a relatively small data set, so just taking more samples for more rigid diagnostic accuracy study would be required. Recent developments have presented more advanced OCT systems, which may permit even higher scanning rates. For example, there is spectral domain full field and swept source full field OCT, which allow the acquisition of entire volumes of OCT volumes to be taken all at once, which would also, which we obviously didn't have access to in our project, but would obviously permit higher scanning rates and greater clinical feasibility. Also, enhanced co-registration methods would be very beneficial for a more comprehensive analysis of image assessment. In our case, there were many cases where histology co-registration was imperfect due to tissue warping or missing of the regions of interest as histology is sectioned. And enhanced co-registration methods have been introduced in order to try and provide a more rigid and comprehensive analysis or image assessment. But what really intrigues me is the development of a learning model for more immediate diagnostic performance using dynamic OCT information, in which all of our dynamic OCT visualization methods may be combined and then through some sort of deep learning model prospected into a binary map in which a surgeon can use in order to immediately prospect either a negative or a positive margin for a given excision. There's also upgrading of underlying methodologies with the goal of increasing computational processing speeds. This could be through GPU utilization, or it could be through parallelization of code processing, which is all, again, something which we didn't really have access to throughout this project. Cool. So just some acknowledgements. I'd like to thank the team at Bright Lab and UWA Medical Physics for all their assistance for my project. Also that my research is to be submitted for publication before the end of the year and will be presented at the following national conferences. So thank you very much for listening. I will now open up to questions from the audience.
Great work, Joel. Really fantastic presentation there.
Thank you very much.
Do you have any questions for Joel?
Yes,
Hey,
I have some. Can you hear me?
Go for it. Yes.
Yep, I can hear you, Pedro.
It's really very nice presentation, Joel. Few questions, if you don't mind, just a quick answer. So, does pressure affect the results or not? When you have the probe.
Yeah, so it's a really good question. For us, when we took images, we did inflict pressure of the sample or compression of the sample onto the imaging window, such to maintain surface uniformity, because our tissue obviously isn't perfectly flat on the top. So we bring it into contact with the imaging window so that there isn't any attenuation through air before it hits the sample. But this undeniably will affect the motility characteristics within the tissue. One thing which we didn't do was compare compressed versus uncompressed dynamic OCT. That's something which maybe future work could look into. But my instinct tells me that in the uncompressed case, you've also got the fact that tissue over our acquisition time tends to, because tissue is quite fluid and it's non-solid, it tends to kind of maybe warp or sink throughout the process of imaging, and this would also induce a constant sort of low frequency motion throughout our acquisition time as well. So compression may also have a dual effect of not only helping with our OCT signal to noise, but also making sure that the tissue or the frequency variation that we do see is based purely by directional motion of the tissue and not due to just the unrestrained kind of fluid motion of the tissue as well. But it's a good question. Did I answer it?
So the other question I have is that your OCT images are suffering from noise. So what was your strategy for future event to reduce the noise substantially before start assessing the data?
So yeah, OCT is obviously susceptible to optical noise, and our penetration depth is quite small, so the point at which we have a high SNR to where noise doesn't become terribly involved is quite superficial. So it's not really something that can be fixed overnight. It's something which I think through enhanced scanning or increased scanning speeds, like for example, I mentioned swept source full field or spectral domain full field OCT. Through modern systems with advanced scanning parameters, temporal averaging could help to suppress noise. I think it's in the more advanced or development of OCT itself, which will be able to help sort of reduce noise, and it's a very system dependent phenomena. Yeah.
Okay, thanks. And maybe the last just suggestions. Did you have ethics for your samples, or is just the form from the patient?
Yep. No, we had ethics approved, in which every patient was informed prior to procedure, and their consent was acquired before participation.
Brilliant. Thanks. All good. Wonderful. Excellent. Well done.
Thanks, Pejman. I've got a few questions, Joel, as well, if that's all right.
Sure.
So you mentioned that the modality is thickness dependent, right? And you sort of struggle to get a signal deeper in.
Yeah.
Does that sort of have clinical implications? So, like, for example, would the thickness of the patient's breast affect whether you can use this method or not? And perhaps even the location of the tumor within the breast, can that affect whether you use this modality or not?
Yeah. Obviously, different excised regions have different sizes and also different margin depths, which are variable. In this project, we didn't really investigate the effect of changing field of view, which is a parameter which can be changed. It is a variable in our imaging. We didn't really investigate how that inflicts or how it influences dynamic contrast, which is something future work could look into, how different varying fields of view does influence the dynamic contrast that is obtained. But naturally, for our application on tumor margin assessment, we are looking at pretty superficial margins, in which we believe that the contrast derivable in OCT is sufficient for. I know OCT has also been used in ophthalmology, dermatology, and I think in some aspects in oncology used for skin cancer diagnosis as well, like obviously due to the really thin penetration depth but high microstructural detail of which it can obtain. So yeah, there is future work to be done in order to inspect how, when things change in size and depth, how that affects the diagnostic accuracy. That is something which, like I said, we didn't really have the means to thoroughly inspect due to our limited data set. But yeah, it's a good point.
Yeah. Excellent. No, that's all good. Thanks, Joel.
Cool.
I think if there's no other questions, we'll stop there. Excellent work.
Wonderful. Thanks, everyone.
Brilliant.
Well done, everyone.